Hi, this is Paul Kelly from TVASurg with an introduction to the first in a series of videos that cover what we've learned about how to depict abdominal anatomy for HPB surgery. This is material adapted from a presentation we gave at the Association of Medical Illustrators meeting in 2015 at the Cleveland Clinic. In case this is the first time you're encountering us, TVASurg is the Toronto Video Atlas of Surgery. Please visit tvasurg.ca to learn more about us. We have been given the privilege to work alongside expert surgeons and document their work, and observe firsthand how they translate anatomical knowledge into planning surgeries to treat a wide range of diseases. Through our work on this project as illustrators, video editors, and animators, we have come to gain a strong familiarity with abdominal anatomy. And in this video series, we'd like to share with you some of what we'd learned about surgical anatomy of the abdomen, in terms of how to best depict it in illustrations, models, and animation, for accuracy and attention to surgically relevant details. We'll each be covering a specific region of interest in abdominal anatomy, with a large focus on the liver, since that's what we see the most of. And we'll talk about the differences we've seen in how this anatomy is typically depicted in static medical illustrations, versus how we've come to know it through medical imaging studies, reconstructing 3D models, editing surgical footage, and building 3D animation-enhanced surgical videos. The first area of anatomy we'll present in this video series is structures above and behind the liver. The second video in this series will talk about the structures inside the liver. And the third and final video in this series will talk about structures below the liver, where we'll share some of the most significant revelations we've had in our work. We'll finish off our discussion of each region with examples of the role each plays during surgery. Before we discuss suprahepatic and retrohepatic structures, we'll give a brief overview of liver segments to begin our discussion. The most common anatomy we encounter in surgery involves the liver, so we'll be focusing on that quite a bit. Let me orient you first to the anatomical position, reminding you that when we say left and right, we mean the patient's left and right. Often when you start to talk about liver anatomy with people who are only broadly familiar with it, they think of the liver as looking like this. And they may recall that there are hepatic veins, hepatic arteries, portal veins, and bile ducts in there somewhere. The shape and appearance of the liver can be deceiving. It looks simple. From the experience we've gained in producing our videos, when we look at the liver, we see something more like this. This region is actually far more complex than we give it credit for. You've no doubt seen, maybe even done an illustration such as this one, where the segments are pulled apart to reveal the structures inside. Something that has always struck me about these kinds of illustrations, though, is what a good case they make for depicting the anatomy in 3D animation, because it's just simply too much information to pack into one still image. So let's begin our journey into abdominal anatomy with a little orientation to begin, and we'll review liver segments based on the Couinaud classification system that most surgeons use. We'll begin with a familiar anatomical view, and remove vasculature for the time being. The liver is divided into segments based on vasculature, both the portal veins entering the liver and the hepatic veins exiting the liver being used as guides to define the borders of these segments. If a liver segment must be removed surgically, surgeons must identify the course of blood flow into and out of that segment, and determine the safest location to divide these structures. We'll rotate and look at the back of the liver. And we can start with the caudate lobe, which is also segment 1. Rotating the liver, looking at the left lobe, we identify segments 2 and 3. I remember which is which by picturing the flat base of the number 2 sitting on top of a flat-headed 3. Rotating to the front, we have segment 4, which the horizontal line through the middle can remind you that it is further divided into segments 4A and 4B. And this is always how we talk about segment 4 in surgery. I've never heard a surgeon use the term quadrate lobe. That's anatomist language, not surgery. If you flip that little lowercase b, you can remember that 4B is on the bottom, because it corresponds to where the gallbladder is found, right at the division between segments 4B and 5. Going back to our segmented liver and rotating to the patient's right, looking at the right lobe of the liver, we'll finish off segments 5 through 8, remembering that they are numbered in a clockwise fashion. We start with segment 5 because the Roman numeral V is like an arrow pointing down. Segment 8 sits above segment 5. Rotating further to the side, we finish with segments 6 and 7, recalling that clockwise order of the numbering with a little visual aid here. So now that we're all on the same page with liver segments, I'm going to pass this off to my colleague Joy, who will be talking about structures above and behind the liver.
Before I dive into what's above and behind the liver, I will first talk about what is on the liver itself. These include ligaments that are attached to the liver and other surface landmarks that help divide the liver anatomically. When we usually think about the shape of the liver, this is probably what comes into our minds. A general wedge shape. Here's the right lobe and here's the left lobe. Right lobe is larger than the left lobe. However, what we've learned from observing numerous HPB surgeries and reconstructing modules from all the CTs, there's a huge degree of variability in liver shape. Here are some examples of variation in liver shape. Sometimes the left lobe is prominent. Sometimes the left lobe is poorly developed. Sometimes the right lobe has a downward tongue-like projection called the Riddell lobe. And sometimes the liver lobes are flattened. In fact, we've learned the shape of the liver can change over time. In this case, from our atlas, the right lobe needs to be removed due to a presence of a tumor. However, the left lobe is too small for post-operative liver function, so a portal vein embolization procedure was performed to induce the growth of the left lobe. And after 4 to 6 weeks, the left lobe grew and the right lobe was then removed. Because of this variation in shape and size, the anatomical division of the liver cannot rely on its shape alone. Therefore, we have learned it is key to understand all the landmarks around and on the liver itself and their relative relationship to each other. The first surface structure I'm going to talk about are the ligaments. The liver is suspended in the abdominal cavity by ligaments. When we think of ligaments, we often picture the thick, fibrous connective tissue that's found between bones. However, in liver anatomy, these ligaments are folds of the peritoneum. They are not thick and fibrous, but usually translucent. I will soon show surgical clips of these ligaments and demonstrate their texture. So these are the ligaments I will be talking about: the falciform, round ligament, left and right triangular ligament, and coronary ligament. As you can see, these ligaments are continuous with each other, so even though they are labeled independently, but it really is just all one structure. So where each ligament starts and ends anatomically is not as important to surgeons. As an illustrator, this means you have more freedom on the position of those leader lines. Looking at the liver from above, you can see the triangular ligaments better on the superior surface. The bare area is the area where there are no peritoneal coverings. I will first talk about the falciform and round ligament. The falciform attaches to the anterior abdominal wall along this line. In most illustrations, you will probably see that everything on the right of the falciform is the right lobe, and everything on the left is the left lobe. This is true to anatomists, however not to surgeons, but more on that later. In all abdominal surgeries, the falciform is the first ligament to be divided after the abdominal wall is opened. Connected to the falciform is the round ligament. It is located at the inferior border of the falciform. Looking at the liver from behind, you can see the course of the round ligament. It forms the left boundary of segment 4B. The round ligament is also known as the ligamentum teres, a remnant of the fetal umbilical vein. Because the round ligament is attached to the belly button, it needs to be divided to gain access to the abdominal cavity. This clip is from a liver resection. The abdominal wall has just been opened, and they're beginning to divide the falciform ligament. Here you can appreciate how thin and translucent the falciform appears. The structure they are tying right now is the round ligament. Note how it looks different from the falciform because it's not a fold of the peritoneum. To HPB surgeons, the falciform and round ligament are viewed as one structure. So when we demonstrate division of the falciform in our videos, it's usually the round ligament portion of the falciform. The falciform ligament is not just in front of the liver, it goes over the dome of the liver as well. As you can see here, notice how the falciform also triangulates out in front of the cava here. On the right and left side of the falciform are the coronary ligaments. It attaches the liver to the central portion of the diaphragm. This ligament is divided, early stages of mobilization, if surgeons need to gain access above the liver. Here, the surgeon is dividing the coronary ligament on the left side to gain access to the left hepatic vein. Again, appreciate how thin and translucent this ligament is. The triangular ligament is located on the lateral borders of the right and left lobe, known as the right or left triangular ligament. They hold the liver to the retroperitoneal wall. Depending on the procedure, one or both can be divided. Here are the triangular ligaments again, viewed from the top. You can't appreciate in this static illustration, but the clip I'm about to show will demonstrate how inferior the triangular ligament extends. Here is the liver. The liver is rotated on the vertical axis of the IVC, exposing the right lobe. Here, the surgeon is dividing the right triangular ligament on top right side of the liver. He then moves inferiorly to divide the inferior portion of the triangular ligament. And here you can see the already divided triangular ligaments on the liver surface. Note how they come together to form the triangular peak here. So here are the most common ligaments we encounter in observing HPB surgery. I hope you will appreciate the look and feel of these real-life tissues. And may these images and footage come in handy in your future liver illustrations. I will now talk about the landmarks found on the liver surface that can be used to identify liver segments, and these will often be used in liver surgery to define transection planes. These include the portal umbilical fissure, the falciform ligament, which I talked about before, gallbladder fossa, and the hepatic vein grooves. The portal umbilical fissure is a structure on the liver I was not really aware of before joining TVASurg. This fissure is on the undersurface of the liver where the round ligament lies. That fissure is partly covered up by a parenchymal bridge. This bridge covers the part of the round ligament that inserts into the portal vein. And to see the fissure, this bridge will have to be divided, which will be demonstrated in this clip. Here the liver is reflected towards the head so the undersurface of the liver is accessible. The forceps is placed through the tunnel, and that tunnel is the fissure. Note the parenchymal bridge here is unusually thick. The size of the bridge varies. Once opened, one can see the relationship of the round ligament with the left portal structures, especially how the left portal vein terminates and fuses with the round ligament. Together with the falciform ligament, this surface landmark will approximately divide segments 2 and 3 from segments 4A and B. The gallbladder fossa is a depression on the undersurface of the liver where the gallbladder lies. The size of depression varies. In this footage, the depression is very prominent because the liver is swollen. However, the fossa is not always that obvious. Sometimes it's just a little dip on the undersurface of the liver, like in this footage. You may have recalled I said surgeons don't use falciform to divide liver into left and right. For surgeons, the middle hepatic vein divides the liver into left and right, and the gallbladder fossa is used as a landmark to find the middle hepatic vein. If you draw a line from the middle of the inferior vena cava to the gallbladder fossa, this line, called Cantley's line, is where the middle hepatic vein lies, and this line is used for both removal of the left or right lobe. This is a clip demonstrating Cantley's line. Notice how this line is away from the falciform ligament. Once the transection is finished, you can visibly see the course of the middle hepatic vein on the graft side. Lastly, the grooves between the hepatic veins will also be used as landmarks for transection planes. The space between the root of the right hepatic vein and middle hepatic vein are known as the right middle groove. The space between the root of the middle hepatic vein and left hepatic vein are known as the left middle groove. Which groove will be used to mark transection planes depends on the location of the tumor. Sometimes both grooves are used as markers if the tumor is found between the right and left hepatic veins. So that's all for structures on the liver. I will now move on to other structures found above the liver, the suprahepatic vena cava and phrenic veins. We're all familiar with the inferior vena cava. It carries deoxygenated blood and it lies posterior to the abdominal cavity. The suprahepatic inferior vena cava, or just suprahepatic cava, is the short section of the IVC that is above the liver and above where the hepatic vein inserts. Note the space between the liver and diaphragm is very short. Despite being short, there are small veins inserting into the cava, the phrenic veins. Phrenic veins drain the left and right diaphragm. These phrenic veins almost act like anchors, anchoring the IVC to the diaphragm. Dividing these phrenic veins will allow surgeons to pull the IVC above the diaphragm down and give additional length to the IVC and therefore more suprahepatic space. This surgical still frame shows how much you can pull the IVC down. That rim there is the pericardial rim, and everything above the rim is the intrapericardial cava. Everything below the rim is the suprahepatic cava. Because the suprahepatic cava is short, tumor of the vena cava can grow into the heart. This was a very rare case we captured where the patient had a sarcoma of the inferior vena cava, where the tumor extended from the right renal vein to the bottom of the atrium. From this footage, you can see how little space we have between the bottom of the heart and top of the liver. The diaphragm is this thin line here. The forceps are pressing on the superior border of the tumor here. So that's it for the top of the liver. Now let's take a look at the back of the liver. The main structure behind the liver is the retrohepatic cava. There are a few vessels inserted into the retrohepatic cava, the hepatic veins and short veins. And lastly, I will talk about another hepatic bridge. Here's what the posterior of the liver looks like. This section here is the retrohepatic cava. It extends from the hepatic vein inserts into the inferior border of the liver. I will first talk about the hepatic veins. The hepatic veins carry deoxygenated blood from the liver to the IVC. There are 3 hepatic veins, right, middle, and left, that inserts into the cava. This is a view of the hepatic veins from the top. Here's the right, middle, and left again. Normally, the right hepatic vein drains segments 6 and 7, but sometimes 5 and 8. The middle hepatic vein drains segment 4, 5, and 8, and the left drains 2 and 3. The caudate lobe has a special drainage, which I will talk about later. Very often, about 60% of the time, the middle and left hepatic veins are found merged together before it inserts into the vena cava. So it looks like there are 2 hepatic veins instead of 3. It is very rare, almost never, to have the right hepatic vein merged together with the middle hepatic vein before inserting into the vena cava. People may think it makes sense to have the right merge with the middle because the right lobe is bigger than the left lobe, but it is not the case. Unfortunately, hepatic vein drainages are not always this straightforward. Sometimes the hepatic vein outflow can be very altered if it's obstructed, like in the Budd-Chiari syndrome. It's not as big of a problem if one of the hepatic veins is blocked because the other 2 can take over. But what happens if all 3 are blocked? This is what happened in this antecedent case. Since all 3 veins and a section of the cava is blocked, the whole liver is drained via the left phrenic vein. These dots show how the left lobe is drained via the phrenic veins. Usually, the phrenic veins insert into the hepatic vein, but in this case, since everything above the liver is stenosed, the phrenic vein branch inserts into the liver. What's even more abnormal is the way the right lobe is drained. Since the right hepatic vein is blocked, the blood from the right lobe flowed into the left lobe via this, what our surgeon called it, intrahepatic collateral crossing vein, and that connects to the left phrenic vein at the middle left confluence. As you recall, the phrenic veins drains into the IVC. But again, because it is blocked, this phrenic ring wraps around on top of the diaphragm and drains directly into the coronary sinus of the heart. If you're interested in how our surgeons approach this case, you can check it out on our online atlas. All of the cases mentioned in this video will be linked below. I mentioned before the caudate lobe is special. Unlike other liver segments, the caudate lobe is not drained by one main hepatic vein, but it is drained directly into the retrohepatic cava via a series of short veins. There are also additional short veins draining segments 6 and 7 of the right lobe too. These short veins are usually divided during preliminary stage of dissection, when the surgeons need to free the retrohepatic cava or mobilize the caudate lobe or the right lobe. In this footage, the short veins are divided to free the IVC from the left lobe and caudate. Note how small they are. This is what the retrohepatic cava looks like when it's completely mobilized from the liver. You can see these numerous suture stumps on the surface of the retrohepatic cava. You can imagine if one of them is not properly tied, it can lead to blood loss. The last retrohepatic structure I will talk about is the retrohepatic bridge. It is a band of tissue located around the inferior vena cava, connecting the caudate lobe to the posterior portion of the right lobe. This structure exists in everyone, but the size of the bridge may vary. This bridge of tissue usually consists of fibrous tissue, but sometimes it contains liver tissue. As you can imagine, the bridge limits the exposure to the right hepatic vein and the right lobe, so it must be divided. The hepatic bridge is divided with care because the bridge may contain large vessels and liver and parenchyma. Forceful dissection may also result in injury to the IVC since it's so close to the bridge. In this living donor right hepatectomy video, the hepatic bridge needs to be divided for exposure and mobilization purposes. The surgeons clamped on either side of the bridge tissue and carefully divided the bridge with scissors. Once cut, the right hepatic vein is much easier to access. That's it for my section. Please check out other videos in the 3-part mini-series on abdominal anatomy for HPB surgery. Paul will be covering intrahepatic structures, and Albert will be discussing structures below the liver.